This conference will now be recorded.
Okay, so continuing with the large bowel, last time we talked about ulcerative colitis and the comparison between ulcerative colitis and Crohn's disease. Some of the acknowledgements. Now we'll be talking about the colonic diverticuli today. First of all, diverticulosis is a rampant, I would like to call it a very common disease in the Western world, not so in India. And if you look at the some of the features of epidemiology, one, as opposed to the Meckel's that we talked about, which is a congenital diverticulum, this is basically an acquired condition. So we talk about an acquired diverticuli, and these are pseudo diverticuli for the simple reason that the wall only has the mucosa and serosa. The muscularis propria is missing. That is, the proper muscle layer is no longer there in this diverticuli. And mostly pulsion diverticuli. Pulsion basically means because of pressure. Rarely, very rarely, they're congenital, when you'll find all the layers of the colonic wall in the diverticulum. And the others are the saccular diverticuli, which are either intramural or may extend up to the serosa. That means basically just indentation of the mucosa into the wall, not extending beyond the serosa of the wall of the colon, right? So either into the muscular layer or to the serosa in the form of ridges. That's why it's also known as the ridge diverticuli. And they have a muscle core. It does not protrude through a gap in the circular muscle as compared to the typical pulsion diverticuli. The most common age group is about 70 years of age. Around 35 years, there's hardly any incidence of acquired diverticulitis, but as the age increases, the incidence increases. The site and geographical, as I said earlier just now, and that is more common in the West, with the reason being the high refined dietary intake as opposed to the high fiber content, as opposed to that in the Asian and the African population. So the Western world, if you look at the Western world, you'll find that the left-sided diverticuli is almost 95%. More than the right side, and primarily in the left side also, primarily it's a sigmoid. 90% of diverticuli found in the sigmoid. Compare this with the Southeastern Asian population, or we as Indians, we'll find that the diverticuli are more common on the right side. The presentation, only 10-25% of patients develop diverticulitis. That basically means that about 80% of them would be having just plain and simple diverticulosis. That means you have a diverticuli, but you don't really have any symptomatology. It's just a chance finding. So if 100 patients have got diverticuli in their large bowel, in the Indian population, about maximum 25%, that means 1/4 of them would be presenting with symptomatology at any time during their lifespan. Now, among these 25% of patients, 10-25% of patients who have diverticulitis inflammation, out of them, 1/5, that means 10-20% of these patients, of these 25% patients, will be hospitalized for treatment. That means they require a inpatient therapy. They have to be admitted. Otherwise, the rest 80% of these 25% can be managed by an OPD management. And out of these hospitalized patients, surgical therapy will be required only in about 20-50% of these patients. That basically means that if you happen to be admitted because of the diverticulitis, your chances of having an ultimate surgery being done on yourself would be somewhere in the region of 20-50%. Coexisting malignancy in these patients who have diverticulitis would be in the region of 12%. This is how it looks like. Just figure that I picked up, and you can see the outpouchings. These are the diverticuli. See these diverticuli protruding out, and from inside it looks like this. The mucosa is penetrating into the deeper layers, right? That's the inner wall of the colon, and this is how it looks like. This is a colonoscopic appearance. This is diagrammatic. This is a colonoscopic appearance. So this is how it looks like. These all indentations are diverticuli. See the propensity of diverticuli out here. Now, if you look at the pathophysiology of diverticulosis, it's a very high intraluminal pressure along a very short segment of the colon. In this case, the sigmoid, which results in an increase in the wall tension. And if there's an increase in the wall tension, it would behave like a Laplace law of pressure, where the wall tension is directly proportional to the radius. So this pressure across the wall, R is the luminal radius and M is the muscle thickness. To sum this up, would be maximum where you have the pressure across the wall and tension across the wall. tension would be maximum where you have a maximum radius. See, T is PR divided by M. While if you look at the pressure across the wall would be maximum at the area with minimum radius, that is the descending colon and sigmoid colon, and that's the reason why there is an increased incidence of diverticulosis in the sigmoid and the descending colon. The pulsion diverticulitis, these are the pulsion diverticuli or mucosal herniation, I would like to call it. These are the commonest diverticuli, and this increase in the luminal colonic pressure results in increased wall tension. And what happens with the increased refined diet? The stool volume is very small, so the colon has to segment more vigorously, and this vigorous segmentation leads to propelling the more viscous feces. Now the feces become so viscous because very small volume, all the water has been absorbed. It's very viscous. So the colon is trying to propel it beyond, and that is why it is not able to do so. It keeps on building more and more intracolonic pressure, and that reflects as an intracolonic wall tension. These patients are usually susceptible to chronic constipation. And with persistence of this high refined diet and chronic constipation, what is going to happen? A muscular hypertrophy and muscular spasm. Irregular coordinated contraction of the affected part of the colon is now seen. Why irregular? Because initially it was a regular contraction, but it has to contract more and more frequently, more and more vigorously. So ultimately it becomes a irregular coordinated contraction. Now this irregular contraction of the affected part of the colon would result in segmentation of the colon. That means each colon is divided into a number of segments, and each segment contracts separately. So segment number 1 is contracting, while segment 2 is relaxing. So it is a separate contraction of each segment. So this becomes, the whole thing becomes uncoordinated. So if it becomes uncoordinated, the force which should have been propelling it along the long axis of the colon, instead what is happening? The pressure is now being exerted at right angles onto the wall. And because being exerted on the wall at right angles to the long axis, the whole of the pressure is now exerted on the wall. The wall tension rises, and that is why it drags, or it pushes, wouldn't call it drag, pushes the mucosa through weak spots. To weak spot. And what are the most weak spot? The entry of the blood vessel. Right? So with the passage of age, along with these increased forces, what else is happening? A decrease in the wall elasticity. Why? Because increased fibrosis with age and loss of tensile strength of the colonic wall. This is age related. Smoking, 3 times higher risk of developing complications. NSAIDs use, steroid use, renal failure, organ transplantation, drug usage, they all increase the risk of complication in diverticulitis. Now, as said earlier, because this high pressure is going to act on the weakest spot of the colonic wall. And what are the weakest spot? That is the entry of the vessel, and that is the side wall of the colon. So the usual site when you find these diverticuli is between the mesenteric and the antimesenteric tinea. Mesenteric and the antimesenteric tinea. So what we're talking about is, this is the mesenteric tinea somewhere here, right? So see, these are basically the, normally finding it at the antimesenteric is not very common. It's not very common. Just have one here out here, but more of them are around the antimesenteric. So that is the site, and that is the reason, because the vasa recta entering the wall at the mesenteric, so there it is weak. So these diverticuli would like to be at the mesenteric border, and they have got 2 coats, one the inner mucosal and the outer serosal. Just not told you the muscle layer is missing. The neck may have an attenuated hypertrophic circular muscle fiber. It may or may not be there, and they protrude through the gap into appendices epiploicy, which we talked about last time. They never penetrate a tinea. They'll be by the side of the tinea, but they never bulge through the tinea. Why? Because tinea is a condensed longitudinal muscle. It has its own elasticity, it's got its own mass. So the tinea cannot protrude through the, the diverticulum cannot protrude through tinea. It has to come to the side of the tinea. It is very rarely seen between 2 antimesenteric tinea, and these are the saccular diverticuli. So remember, between the mesenteric and the antimesenteric, not between the 2 antimesenterics. This basically, the pathophysiology was happening initially. This is the diverticulosis. There is intracolonic pressure. The mucosa out here, it is pushing it out. Now what is happening? In the second stage, there is a symptomatic, uncomplicated diverticular disease. So what is happening now is, there's alteration in the microflora out here. The microbiota is changing. That means the bacterial concentration, because this, remember, diverticulosis forms a stagnant area of the colon. This is a stagnant area. It is out of the normal circulation of the colon, out of the normal lumen of the colon. So it becomes stagnated. And because it becomes stagnated, the bacteria are going to multiply. So there's alteration in the bacterial flora and the concentration of the bacteria, number one, leading to what? A low-grade inflammation. And because of the low-grade inflammation, that leads to visceral hypersensitivity. Why? Because the mucosa is now being affected by the low-grade inflammation. Right? Now, that is a symptomatic, uncomplicated. Until now, complication not occurred. But now, next, what is going to happen? Next, what's going to happen is that there is going to be actual inflammation. Now, here there was just colonization. You can call it a stage of colonization. SUDD is the stage of colonization. But next stage is basically a stage of infection or inflammation of the mucosa, what we know as a diverticulitis. And from the mucosa, the infection now spreads to the outer wall, that means the submucosa, more outer to the muscular layer, more outer to the serosa, more outer it goes into the peritoneal cavity. So now you have the diverticulitis, and that is because of what? Because of the ongoing alteration, it keeps on multiplying. What else happens? Now there's a disruption of the mucosal barrier. See, the disruption of mucosal barrier, and all this is aided by what? A fecolith which is impacted out here. Why is fecal impacted? Because the food or the fecal content which is lying out here is stagnating. More and more water is being absorbed in the diverticuli. So what remains behind? A very, very hard fecal mass. So that fecolith gets impacted in the diverticuli. And once the mucosa is damaged because of pressure of the fecolith and the inflammation, it leads to what? Translocation of the bacteria, leading to inflammation and ultimately leading to onward transmission to peritoneal cavity. So two things are working. There are the three I would call it. Number one, colonization, multiplication of the bacteria. At the same time, a fecolith forming out here, both of them together, one by trauma and the other by inflammation per se. Both of them lead to what? Mucosal disruption and ultimately inflammation of what we call as diverticulitis. So that is the genesis of diverticulitis. How do you investigate a patient of diverticulosis? Number one, the best is probably a CT scan. A CECT is the best, and that would be a preferred for acute and complicated presentation. But if you have an uncomplicated patient, then the whole basis of diagnosis rests on a colonoscopic examination. So uncomplicated diverticulosis, you suspect the diverticulosis, go ahead and do a colonoscopy before you go in for a CT scan. So this should be the first investigation in an uncomplicated diverticulosis. In a complicated, it has to be a CT scan. Why? Because it's non-invasive in the sense that you're not altering you're not doing anything to the lumen. Because if it's inflammation, you try to push something into the lumen, you may likely lead onto a perforation. So colonoscopy helps by what? Differential diagnosis from carcinoma colon, which is very, very important, and immediately tell you, look, there is nothing wrong with the mucosa except that there is diverticular protruding through the mucosa. There are dipping areas from where the mucosa is going out into the wall, and number two, there may be surrounding inflammation of the wall, very small inflammation, and then you can take a biopsy. And if there has been a diverticulitis, please do not do a colonoscopy before 6 weeks. That means you give 6 weeks for the bowel to be rested, only then go ahead and do a colonoscopic examination. So in that scenario, when you have an acute attack, your diagnostic capability would rest on what? A CCD examination. It tells you what? Number one, it tells you about the complication in the form of, it will tell you the bowel wall is thickened, it will tell you where the bowel is distended, it will tell you there's an abscess formation, a localized peritonitis, a fistula. All these can be diagnosed on a CT scan. And you can go in for a guided therapeutic drainage of an abscess. That's an added advantage of a CT, where it can guide you to carry out a therapeutic procedure. On the other hand, a double contrast barium enema or water-soluble contrast enema, 90% of the time will give you a sawtooth appearance or a stricture formation, and then you decide that yes, I'm looking at a patient with diverticulosis. The other investigation, especially when you're suspecting colovesical fistula, go ahead and do a cystoscope examination, or an angiography can be done for differential diagnosis from angiodysplasia. Now you may well ask, why the hell are we talking about angiodysplasia? For the simple reason that one of the very common presentation of a patient with diverticulosis is hemorrhage. Perhaps the most common presentation, a symptomless. That basically means that apart from the hemorrhage or bleeding, there's no other symptomatology, and that is also there in angiodysplasia. And these are the two commonest causes of hemorrhage in the plus 60 years age group of patients, right? That is why it needs to be differentiated, especially in the upper age group, and there you have to resort to the use of angiography. A place diagram of the abdomen has been mentioned as the last for the simple reason that it is usually helpful in those patients where you're suspecting a perforated diverticulitis. So what are the clinical presentations and complications? Number one, it presents as a asymptomatic, which I said earlier, in almost 80 to 90% of patients, it's asymptomatic diverticulosis. Symptomatic, 10 to 25%. That means out of 100 patients who have diverticuli in their colon, only 10 or 25% of them would be presenting with some kind of a symptomatology. The first type of presentation of a symptom would be an uncomplicated SUDD. That basically means that this patient is presenting with absolutely non-specific presentation in the form of distension of the abdomen, flatulence, heaviness of the lower abdomen. And there it has to be differentiated with what we commonly know as an irritable bowel syndrome. Now, why does this happen? This is basically the food which is loitering about in the diverticuli, lying there, bacterial multiplication occurring there, soiling of the diverticuli, and low-grade mucosal inflammation. The second commonest presentation is hemorrhage. Second commonest is hemorrhage. I just not told you that. The third is acute inflammation in the diverticuli. So, diverticulosis, no complication, asymptomatic. Number two, I have some symptoms. Number three, I have had hemorrhage. And number four, I have diverticulitis or complications of diverticulitis. So there's four eventualities in a presentation of diverticulum: asymptomatic, symptomatic, number three, hemorrhagic, and number four, symptomatic with diverticulitis. Now, when you have diverticulitis, it can present in two forms, either as an uncomplicated diverticulitis, that means just inflammation, it's taken care of by just normal therapy, and it goes away. But it can become a complicated diverticulitis. What's a complicated diverticulitis? A complicated diverticulitis is a diverticulitis which keeps on recurring. It occurs today, 3 months, 4 months down the line, again I have diverticulitis. That is a recurrent diverticulitis. Or else I have a pericolic abscess because the infection from the mucosa went to the muscle layer, to the serosa, and it formed a serositis and peritoneal inflammation, that is the peritoneum lining my colon. There's a formation of pericolic abscess. Or there has been a frank perforation in my diverticulum and I develop peritonitis, which is inflammatory and because of perforation. Or because of these pericolic abscess or inflammation of the outer layer of the colon, the bowel tends to stick to each other, leading to an acute intestinal obstruction. So this is acute intestinal obstruction, usually a adhesive intestinal obstruction. And of course, fistula formation occurs in those patients where the diverticulum is lying in close opposition to the bladder. There is infection in the diverticulum. The inflammation of diverticulum leads to its adherence to the bladder wall, and if the diverticulum perforates by chance, it leads to leakage into the bladder, leading to what is known as the colovesical fistulas. Right? So diverticulosis, uncomplicated. What do I do? How do I get myself treated? Just 4 things: high fiber diet, rifaximin, probiotics, and mesalazine. Now, this is basically what is and how they work, the mechanism of action. Among all these, perhaps the most important is changing the diet lifestyle of the patient from high refined diet to a high fiber diet. And that high fiber diet gives you bulk to the feces. And that bulk is easily propelled forward by the colonic wall. It doesn't require too much force by the colonic wall, as opposed to a refined diet, which becomes viscous, very small amount, and the colon keeps on trying to push it, not able to do so, and leading to increased wall tension. So change the dietary lifestyle of the patient. That basically is a high fiber diet. Rifaximin basically would act by altering the microbial flora there. So it decreases the metabolic activity of the intestinal bacterial flora, that gets decreased. It decreases the hydrogen methane production, increase the fecal mass, and eradication of bacterial overgrowth. So basically what we're looking at in this patient is that we are trying to control the bacterial multiplication in that diverticule. A probiotic again helps by acting on the pathogenic bacteria, and mesalazine is a drug which inhibits the inflammatory cascade. So this is an uncomplicated diverticular disease where I was having this flatulence and this vague pain in the lower abdomen and abdominal distension. Now, what happens if I get inflammation and I'm still in the uncomplicated stage of diverticulitis? In these patients, where diverticulitis occurs, fever, pain becomes now persistent. In diverticulosis, it was intermittent pain, now it becomes persistent. I may have diarrhea or constipation. A lump may or may not be palpable. When does the lump become palpable? A lump becomes palpable when a peridiverticular phlegmon forms. That means the diverticulum has been inflamed. The body tries to limit that inflammation. What immediately rushes to the spot? The omentum, great omentum. What else? The small bowel and the adjacent large bowel. So everything sticks up now, giving rise to a lumpish feeling or a lump formation. How do I get investigated? By a CT scan. It easily shows a pericolic fat stranding. It can show a colonic wall edema. It can show a phlegm. So all this can be easily diagnosed by a CT scan, which could be a CECT, a contrast enhanced, where I take an oral contrast and it gets deposited there, and I can easily see the diverticle. Treatment is very simple in these patients, just OPD treatment. And I said earlier, it is simply just changing the diet pattern to high fiber, antispasmodics for decreasing the intensity of the contraction, which is giving rise to the pain. So the pain disappears. And antibiotics and probiotics for tackling the bacterial multiplication, which is there. Now, 10 to 20% of these patients, remember earlier I said, of these uncomplicated diverticulitis become complicated and they require hospitalization. So what is in hospital? They'll have to be put on intravenous antibiotics. Oral restriction has to be done. Catheterization is an important part that reduces the risk of a colorectal or a colovesical fistula, not colorectal, colovesical fistula. Now, what about the antibiotics and diverticulitis? Now, this is a consensus statement, and that is published by the American group. In the outpatient, amoxiclav combination is the best, perhaps best, or you can use a combination of trimethoprim sulfamethoxazole or fluorochloroquine or metronidazole. If you are an inpatient, then these drugs can be used as an IV, or they can combine with aminoglycoside or monobactams or third generation cephalosporin. So this gives you a list as to what can be or which antibiotics to use in an inpatient and which antibiotics to use in the outpatient. Now, when it becomes complicated, diverticulitis. So now I've had diverticulosis. Unfortunately, I had diverticulitis. I was treated, but more unfortunately, I had a complication of diverticulitis. Now, how do we classify diverticulitis so that it helps us in deciding whether it really requires or what is the severity of diverticulitis? And for that, the modified Hinchey classification is the best classification, which is taken resort to. Stage 0 is mild clinical diverticulosis. That means in these patients, there has been no inflammation, just plain simple diverticulosis. Stage 1A and 1B are these confined pericolic inflammation of phlegmon and abscess formation. So now in the second stage, it is an abscess formation around the colon, that is the pericolon. Stage 2, now what has happened is pelvic or distant intra-abdominal or retrograde abscess. So now the abscess is at a distant site, not only the pericolic site, it is a distant site. Now, when this occurs, now there are always chances of a generalized purulent peritonitis, which becomes a stage 3. And when this purulent, instead of pus, a fistula forms and fecal soiling now occurs, then it will be known as generalized fecal peritonitis. So that becomes the most severe form of manifestation, right? So these complicated diverticulitis can, with this classification, you can easily see it can present as a phlegmon, it can present as a pericolic abscess, it can present as a retroperitoneal abscess or a distant abdominal abscess or a purulent peritonitis or a fecal peritonitis. And on top of all that, this patient can present with fistulae, hemorrhage, nasal obstruction, and perforation peritonitis, right? Now, coming to the acute diverticulitis, the treatment, if it is uncomplicated, just not told you, uncomplicated, if the patient happens to be immunocompromised, or the signs of generalized infection, affected general condition in the form of high-grade fever. The patient has a lot of malaise, the appetite is gone, and the patient perhaps has got a severe comorbidity. Let's say he has got a pre-existing heart disease, or more important, a diabetic patient. So in all these patients, or the patient is more than 60 years of age, in all these patients, you can start with an outpatient treatment. If the outpatient treatment does not work well, then you have to change the antibiotics to a broad spectrum. And number two, you may have to admit the patient, right? So in uncomplicated acute diverticulitis, these are the patients who may require inpatient therapy. The second group is a patient where the diverticulitis has complicated itself. That means the Hinche 1B or 2. And what is Hinche 1B and 2? 1B and 2, you can see it is pericolic abscess, and 2 is a distant abscess. That means it has not still become a generalized disease. It is localized. And pus pockets are localized. When one, the pus pocket is around the divertically, in the second, the pus pocket is at a distant site, like the pelvic abscess. So if that is the scenario, these are small abscesses less than 4 to 5 centimeters or larger abscesses. Along with antibiotic, you can hope to aspirate these patients, right? You can hope to aspirate the patient, a CT guide. But if you find that this patient got Hinche 3 or 4, means what? A generalized purulent or fecal peritonitis. These patients have to be explored, and the emergency surgery has to be done. Hemorrhage, which, as I said earlier, is one of the most important presentation diverticulitis. It is usually painless, profuse, and often persistent, right? Or it can be intermittent. The blood is bright red. If it is a sigmoid bleed, if it is more proximal bleed, like for example, say the cecum or the ascending colon, then the blood tends to change its color to a darker hue. Often associated angiodysplasias are there, and 80%, fortunately, the bleeding stops by itself. So this is how the bleeding occurs. See these two sides where the bleeding is occurring. So these are the vasa recta which have entered, and these are the, remember we told you about the straight vasa recta and the curved vasa recta supplying the wall circumferentially or entering into the wall through the mesentery. So these are the sites where you can have the bleeding. This is the mesenteric side, the antimesenteric side. At both the sides you can have bleeding. The diagnosis very easily done. I wouldn't say very easily, because in the presence of a large amount of bleed, colonoscopy examination becomes problematic. So you can do a colonoscopy, you can do angiography. Remember, I told you it has to be differentiated from angiodysplasias. The treatment, simple. You do a colonoscopy and use a cautery to burn this out. You can easily burn this out. By what? By any kind of cauterization of energy source. You can use energy source. It could be a laser source. It could be ultrasonic source. It could be a cautery source. So either of anyway, it has to be any kind of energy source which burns the bleeding out. Number two could be arterial embolization, and number three could be segmental colectomy in those patients where you find a large segment of the diverticulum involved, or and all of them got diverticulitis. So that whole segment has to be removed. Now, what are the surgical options? Number one, I have a problem. This is the disease colon that I have. I am symptomatic. A single stage resection. This thing is removed, and a colocolic anastomosis is now done. That is the operation of choice in an elective scenario. But if I happen to land up in an emergency, I had this diverticulitis, I have a perforation, or I have got hemorrhage, or a fecal peritonitis, or purulent peritonitis. In these cases, what's to be done? Number one, you excise this whole thing, close this end, and bring this out as a colostomy. This is what is happening. See, the lower end has been closed, so excision here, close this end. That is the rectus stump. And then removing this, you have got a segment of the colon which is opening like this. So bring this out. So the part in between these two ends has been excised. So that has been a single stage resection with anastomosis, or else in this patient where there was fecal soiling, I can't do anastomosis. Why? Because number one, either this distance is too long, I had to excise the long segment, or else I didn't want to do anastomosis in a medium or in a surrounding which is teeming with bacteria. Purulent peritonitis, try to do anastomosis, the chances of anastomosis breaking open is very high. So in these patients, what is preferred is a Hartmann's operation, or you can do a temporary proximal colostomy. Just do a temporary proximal colostomy. That means you extrude this whole segment. If you extrude the whole segment, becomes a colostomy. Or you can do a extended repair, as I said earlier. A colovascular fistula, if the patient has to land up with a colovascular fistula, in these patients, the whole of the fistula tract has to be excised. And if the patient has got hemorrhage, I told you cauterization, but with a non-identification of the site of bleed and the bleeding still persists, in that case, I would have to go in for a subtotal colectomy with ileostomy. Now, the easily said than done. Why? I said earlier, I just not told you that the site of bleed may not be evident, but the site of diverticle is there. I can see the diverticle. So I take it for granted the bleeding is occurred from there and I will excise that segment. I just now told you the most important differential diagnosis is what is known as angiodysplasia. What exactly is angiodysplasia? When you say the word angiodysplasia, you're basically talking about a very common vascular abnormality in the GI tract in which there has been a degeneration of the wall of the vessel and presents either as an isolated lesion or as multiple vascular lesions. And the site, the most common of these angiodysplasias is the cecum and the proximal ascending colon. The small bowel angiodysplasia are also there, but they account for only 30–40% of GI bleed of obscure origin. They are responsible for what? Responsible for approximately 6% of lower GI bleed and 1 to 2% of upper GI bleed. So they are not unimportant causes. Angiodysplasias are responsible for 6% of lower GI bleed and 1 to 2% of upper GI bleed. So they have to be basically looked for in a high suspicion index surrounding. Mainly in patients over 60 years and increase with age, just like in diverticulitis or diverticulosis, which is a post 60 years age group disease. Predominantly, even angiodysplasias are more common over the 60 years and they increase with age. And I said earlier, remember, second leading cause of lower GI bleed in patients older than 60 years after diverticulosis, and this has to be remembered. That after 60 years, if a patient comes to you with a painless hemorrhage or hematochezia, you would immediately think of two things. One, I would look for diverticulosis. Number two, I look for angiodysplasia. Fortunately, with angiodysplasia, the prognosis is good. Why? Because the bleeding stops spontaneously in almost 90% of these patients. So what is the etiology? I just now told you it is a degenerative change of small blood vessels treated with aging. That's the most widely accepted theory. And these abnormal vessel walls are reduced to what? Just an endothelial lining with minimal or no smooth muscle and a serosal lining. So I just have a vessel and my vessel wall has got just two layers to it, endothelial and serosal. The intervening mucosal layer has been degenerated. Now, why does this occur? Idiopathic is the most common. Number two is a long-term local hypooxygenation scenario. Because of some reason or the other, the microcirculation of the colon has suffered in the sense that it has received less amount of oxygen, either because of less amount of blood flow or whatever reason. But the oxygenation of my mucosal cells has been affected. So the hypooxygenation circulation from either cardiac, vascular, or pulmonary, any reason, these are primary, ultimately they leading to what? Colonic hypoperfusion. And that hypooxygenation and hypoperfusion of the colon would be a scenario or would be a setting where angiodysplasia will occur. Now, there is a doubtful association with end-stage renal disease, with von Willebrand disease, which is a left ventricular assist device, and aortic stenosis. All these are commonly seen to be associated with angiodysplasia. The hypothesis of angiodysplasia, why this occurs, I just now told you that is idiopathic or some reason of hypooxygenation or some disease related. But basically what is happening in all these conditions, is that based on the Laplace law, again we're coming to that, the wall tension is highest in bowel segments with higher diameter. That means the right side of the colon. That gives you an idea why angiodysplasias are more common on the right side and diverticulosis is more common on the left side. Remember this, diverticulitis or diverticulosis primarily left and angiodysplasia is primarily right. Now, what is happening in this patient? There has been repeated colonic distension leading to what? Multiple episodes of increased wall tension and contractility at the level of muscular propria. So the colon is contracting time and again, time and again, time and again. So what's happening? A repeated colonic distension. Now what happens? Some mucosal veins become chronically obstructed and dilated. So my vein is now chronically obstructed. So the proximal part of the vein, which is lying proximal to the part where it is obstructed, that proximal venule and anterior capillary units, they're feeding them, they now become dilated. And this dilatation, ultimately the whole of the capillary unit dilates, which is the capillary unit from the artery, the precapillary, the capillary, and the postcapillary. The whole unit. Now that dilates. So the precapillary sphincter now loses its competence and becomes incompetent. And if the precapillary sphincter becomes incompetent, a small arteriovenous communication now forms, which does not have any valve. It's not a functioning valve anymore. So it becomes a functionless, valvular functionless. And this accounts for what? The early filling vein observed during the mesenteric angiography, and the process is probably age-related. Now, one thing is very remarkable, and that is that this whole scenario or the whole pathophysiological series of events occurring probably do not apply to lesions upper GI tract despite being morphologically identical. Increased expression of angiogenic factor is the second hypothesis, and you find in these patients an increased level of basic fibroblast growth factor and vascular endothelial growth factors. The clinical presentation, asymptomatic. Number two, varying degrees of anemia. But the third one is the most formidable and morbid presentation, and that is GI bleed, which is painless in varying amounts, either it's a small amount of bleed or a huge amount of bleed, and presenting as hematochezia, occult blood, or melena. This is the presentation of a patient with angiodysplasia. So the pattern of bleeding either could be fresh blood or it could be occult blood. You do a stool analysis, find occult blood, or there could be melena in this patient. The site of GI bleed in order of frequency, if you look at the site of bleed, just see this. The most common, number one is cecum, next comes the rectosigmoid, and then the rest of the colon. The smaller it is seen, the stomach or anal site are less commonly involved in angiodysplasia. In the diagnosis of this condition, number one, lab investigation not very helpful. It just tells you what? Intermittently positive occult blood, that's one. Number two, a low hemoglobin. Why? There is either an obvious bleeding or there is a non-obvious bleeding, which is just occult blood in the stool. Ultimately, it's going to lead to what? A low hemoglobin and a low iron level. An upper GI endoscopy or a capsule endoscopy or a double balloon endoscopy in those patients where you're suspecting a small bowel angiodysplasia. But if you have a colonoscopic angiodysplasia, then you have a colonic angiodysplasia, a colonoscopic examination helps you. It's got a very high sensitivity and a positive predictive value nearing 90%. So this forms a very good investigation. Colonoscopy is a very good investigation for diagnosing or identifying the site of angiodysplasia. And if you look through the colonoscope and if you have a angiodysplasia, it would look something like less than a centimeter, 5 to 10 millimeters, that is 1 centimeter or less, of a flat cherry-ripe fern-like projection vessel. What are these fern-like projecting vessels? The venules originating from a central artery. Radionuclide scanning is again a good method of investigation, but then it is a good method in those patients where colonoscopy cannot be done. I said earlier, in those where you got a severe inflammation of the colon. So it is the most sensitive radiological diagnostic tool during active bleeding. Number one, it can detect bleeding to the tune of 0.1 to 0.5 ml per minute. And what are the isotopes that you use? Two. 99M, technetium pertechnate, and sulfur colloid. As the name suggests, sulfur colloid, because it's a large particle, then these could be taken up only by the phagocytes, right? So technetium sulfur colloid, the half-life is only 3 minutes, only 3 minutes. That means the moment you inject, within 3 minutes, half of it would be gone, and within a couple of minutes, the whole of it is washed out. So if you're using that, an active bleed can be identified. But suppose the patient is having intermittent bleeding, you can't identify with technetium sulfur colloid, and that is where the technetium pertechnate scores over a technetium, and that's why scores sulfur colloid, and that's why it says it can also be used to diagnose remittent bleeders. So that is why that is the better radioisotope in those patients where there has been recurrent bleeding because of angiodysplasia. The biggest drawback of the radionuclide scanning is, does it have a drawback? Is it does. And that is the site of bleed when shown may not correlate well with the specific site of bleeding. Why? Because of active peristalsis. The other methods of examination or investigation, helical CT angiography, a sensitivity, specificity nearing 70 to 100%. 100% is very good, 70% not very good, but more results during active bleeding with a minimum rate of bleeding of that is the minimum amount of bleeding that it can identify. So any lesion less than 0.3 to 0.5 ml a minute being of blood being pushed out in these patients, it is a very good investigation. An MRI can be done equally effective as a helical CT, but angiography is probably better, and it's specially reserved in those patients. Number one, there is active bleeding, hemodynamically unstable patient where you can't do other investigations, patients in whom the active source of bleeding remains unidentified, even with conventional diagnostic method. And what are the conventional diagnostic methods? We just not talked about that. Colonoscopy is the most important, right? Then, or you can do a radionuclide scanning. With that also, you're not being able to identify the site of bleeding. Now, this requires only a bleeding of less than 1 ml per minute for identification. So, even if I have a bleeding of only 1 millimeter or less, my CT can easily pinpoint, look, there's the lesion for you. Next time it's going to bleed more. Go and look at it and do something about it, right? So, any bleed of 0.5 to 1 ml per minute, the blood loss of that amount of blood loss can be diagnosed based on angiography. But unfortunately, the sensitivity and specificity are not very good. The sensitivity is anywhere from 58%, 86%, which is not a very good, nothing to write home about, not a very good figure of a sensitivity figure. Three characteristic signs can be seen on angiogram. If you do angiography, what you're looking for? Three characteristic signs. Number one characteristic sign is a densely opacified, dilated and slowly emptying draining vein within the intestinal wall. And why is that happening? Because of irregular contraction of the muscle. It keeps on pressing on the pulsation of the flow of the vein, and that's why basically it was looking, this appears a densely opacified, dilated and slowly emptying draining vein. The second thing that you can look at is a vascular tuft. And what is this tuft? It's nothing but a lot of veins coming out from the artery, and that's seen on the arterial phase of the angiogram. An early filling vein may be observed in the arterial vein. So three characteristic signs. You can well say that there is bleeding, the dye should extravasate. Yes, can extravasate, and you can find the dye lying inside the lumen. But unfortunately, that happens only in 6 to 20% of the patients. The rest of these patients, they do not show any leakage of the radioisotope injected inside the blood into the vascular compartment in that particular area. Intraoperative endoscopy can also help you. You have opened the abdomen under the belief that I would be able to identify the angiodysplasia. I'm not able to do so. So now what do? I push an endoscope, make an enterotomy, push an endoscope, and try to visualize the luminal side of the bowel. So when you're opening the abdominal cavity, you're seeing the serosal side of the bowel. You're not seeing inside the lumen of the bowel. So here you're seeing inside the lumen of the bowel if you're doing an enterotomy, right? Now the treatment, if it is incidental, a colonoscopy has been ordered for some other reason, and they find there is diverticulitis, no episodes, past attack of inflammation, don't do anything. Just leave it as such. But if there is active bleeding, and that active bleeding, with active bleeding, the patient has still got a stable cardiovascular condition, hemodynamically stable. In these patients, endoscopy is advised and manage the cytopenia. But if by chance this patient has got a hemodynamically unstable condition, then prior to any of these, you have to manage the hemodynamics in the form of controlling the blood pressure, the pulse, the urine output, the cardiac perfusion, and so on and so forth. So you're trying to normalize the whole of the cardiovascular status of the patient, only then go in and tackle and do an endoscopy and subsequent management. What do you do in endoscopy or colonoscopic management? Number one, I can burn that particular area, angiodysplastic area, with the help of my argon plasma coagulation ablator, by electrocoagulation, endoscopic clips, a band ligation, a sclerotherapy, and two sclerotherapy is most commonly used. Number one is polypropanol, and number two is sodium tetradecyl sulfate. Or I can use a laser beam to burn this out. So these are the methods by which the area can be usually burnt out with the help of a endoscope or a colonoscopy. What else can I do? What else can I do? Well, number one, I can do some kind of a manipulation through the arterial compartment inside the vessel lumen. And what is that? Temporary absorbent gelatin sponge can be put at the site of bleed. Number two, there could be local infusion of a vasoconstrictor. But I can block the arterial lumen with the help of a temporary or a permanent embolization with what? With microcoils, particles, or glue, whatever. I can use anything inside the arterial lumen to block it. So that could be an alternative for all the patients. So remember, permanent embolization with microcoils, particle glue. A surgical treatment is indicated angiodysplasia only those patients where routine conservative management has not been successful in stopping the bleeding. So if that has happened, I can go ahead and do a limited resection. Or there could be a scenario where there has been a failure of treatment and the site has not been localized. One, I knew there was bleed and I know that it's occurring at point A. So let me remove that point A. But if I don't know where point A is, where the bleeding is occurring, that becomes a very, very formidable scenario. Why? You often land up doing what? A total colectomy. So this is a group of patients. This group of patients is a patient where unnecessary surgery may be usually indicated. I can use angiogenesis inhibitors and I can use octreotide. Octreotide basically is effective in the treatment of refractory angiodysplasia, right? The differential diagnosis is not very difficult. You're looking at any cause which is causing painless bleeding, any cause. It could be peptic ulcer, coming down the line, diverticulosis. It could be colitis, it could be hemorrhoidal bleed, GI malignancy, and so on and so forth. You can go through the list. In all these conditions, it is always a painless hematuria. Coming to probably the last part, that the ischemic colitis, sorry, the second last, just two things more. Ischemic colitis, if you remember when we talked about ischemic chichinitis, it is also a similar condition in the sense that there has been vascular compromise. That's why the word ischemic, ischemia has occurred. And that is the most common form of gastrointestinal ischemia, accounting to 50 to 60% of all cases. It is usually segmental and it could be non-gangrenous ischemic colitis that accounts for almost 85% of cases. That basically means what? That means that if I've got ischemic colitis, 85% of those patients who have similar ischemic colitis, they would not be required any kind of in therapy. Outpatient therapy can be done. Why? Because in all these patients, what has happened? There has been a non-gangrenous and segmental ischemic colitis, right? So it can be tackled with the help of just plain and simple conservative management, and complete clinical recovery occurs in 1 to 2 weeks as the colonic mucosa regenerates, and overall mortality is in the region of 22%, which in this scenario is a very low mortality. Otherwise, it's a high mortality, but in this scenario, it's a very, very low mortality. Severity of disease and ultimate mortality is higher in a right-sided disease. 20% of patients who require surgery have an associated mortality rate of 10 to 65% and can be as high as 75%. So remember, in ischemic colitis, you're looking at some kind of a surgical intervention, but you're also looking at a highly morbid surgical intervention. What is the anatomical basis of ischemic colitis? Areas of colon which are most sensitive to decreased blood flow, known as watershed areas. So these are watershed. Why they are watershed? Because these are those areas where there is a compromise, or there could be a compromise of the vascularity, right? Now, look at the splenic fracture, known as the Griffith's point, and there the anastomosis superior mesenteric artery and the inferior mesenteric artery. Look at this figure. So that is the Griffith's point. This is the superior mesenteric, the inferior mesenteric. This is the arc of Riola. Remember from last time, meandering mesenteric vessel, arc of Riola. And there you got the dermoid arcade. But when you got the dermoid arcade, how does it form? Formed by the number one branch of the right side of the colon and the branch of the left colon. So the junctional area in this particular area, the Griffith's point, is absent in 5%. So 5% of these patients would not be having any anastomosis there, right? 50% of the population would be having a poorly developed. So either the marginal anastomosis Griffith point is absent, there's incomplete artery, leading to increased risk, or in the rest of the 50% patients, there is a poorly developed marginal artery. There is also evidence that colonic arteries become more tortuous with advancing. So that could be another reason why you have angiodysplasia. But overall, the watershed anatomy of the colon provides an excellent reason why, number one, the left colon splenic flexure is involved in 75% of ischemic colitis cases. Why? Because in 5%, the anastomosis between SMA and IMA has not occurred, and in the rest 50% also it has been compromised. So these patients would be presenting with a high morbidity. Okay, so left colon and sigmoid splenic flexure involve 75% of cases. Number two, the rectum is involved only in 5% cases. Why? Because it's got a very rich blood supply. It's got supply both from the internal iliac and from the superior rectum. So even if you cut off the superior rectum, it's not going to hamper the function of the rectum. So we have these 2 points, the Sudex point, there's a Sudex point, which is an anastomosis point between what? See the superior rectal artery coming from where? From the inferior mesenteric. And from the sides, you've got branches of the internal iliac directly supplying it. So that again forms an anastomotic site. The Sudex point and Griffiths point. Now classification, it could be a clinical classification, or it could be a Band and Bailey classification, Bowle classification. The clinical classification is probably easier to remember. Number one, non-gangrenous, and number two, gangrenous. Simple. Either I have a gangrenous colitis or I have a non-gangrenous colitis. If it is gangrenous colitis, it could be a gangrene only of the mucosa, which recovers. The serosa was not involved, the muscle was not involved. It is only revealing to the mucosa. That could be a transient form. Or it could be less acute, but in a low-grade inflammation for a long period of time, it will be chronic non-resolving form. You could be having stricturing form, and you can have partial necrotizing, right? This is ischemic colitis, which is occurring. Why? Ischemia has occurred. Whenever ischemia has occurred, the repair process taken recourse to is fibrosis. So you can have a stricture formation. Or you can have a partial necrotizing form where only a patch of mucosa has been affected, so that becomes partial necrotizing. Gangrenous, on the other hand, comprising 50% of population, there is a transmural necrotizing form. That means necrotizing transmural means what? Mucosa necrosis is there, the submucosa necrosis is there, the muscle necrosis is there, and even the serosome necrosis. So it becomes a pan or rather full wall necrosis. The Band and Bailey classification, on the other hand, classifies as a reversible and transient, chronic ulcerative, ischemic stricture, gangrene, and fulminant universal, or what is known as the pancolitis. Right. Now, you look at the symptom, the left colon, I said, is 75%, splenic flexure 25%. The isolated right colon ischemia, ischemic colitis, is found in only 10% of cases. And look at these 10% of cases, the presentation of abdominal pain without bloody diarrhea, associated hemodialysis, chronic failure, shock patients, severe form of colitis, highly morbid, 2 times more mortality than those with colonic ischemia involving other regions, and 5-fold need for surgery. The cause why it is occurring on the right colon or the right-sided isolated right-sided colon ischemia, one is insufficient collaterals, which we know, yes, the collaterals are there, are less in the right colon, more in the left colon, and of course a possible association with some mucosal association. Now, looking at the symptomatology, either it is basically very easily translated as site and the severity dependent. So that would determine what presentation this patient is going to present with. A non-specific abdominal pain, NSAP is non-specific abdominal pain. Most common presentation, sudden and crampy pain, which you all call as a griping pain. It is mild and localized over affected area, usually the left side of the lower abdomen and the hypogastric. It can present as diarrhea. So one, it is a non-specific abdominal pain. Number two, diarrhea. Number three, an urge to defecate, a strong urge to defecate. And number four, mild rectal bleeding, which are the common manifestations. And if you have a right, it's a minimal rectal bleeding, mild rectal bleeding. The reason it is occurring within 24 hours, bright red or maroon, frequently mixed with the stools. And why is it occurring in these patients? Because of inflammation leading to rupture of the vessel. There could be associated ileus and with the ileus, it's associated in the form of nausea, vomiting, and anorexia. Then metabolic acidosis and septic shock are all symptoms of ischemic colitis. The finding is simple, and that is abdominal tenderness, mild to moderate tenderness over the affected area of the colon. So if I've got a ischemic colitis of the left side of the colon, my pain would ultimately be reflected in that particular point. Initially, it's always what? Epigastrium, hypogastrium, or umbilical. It's all in the midline. Remember when we talked about the development of the gut? We said that, right? So DRE, you do a digital rectal examination, you land up with blood-stained fingers. And fever is unusual. And if you look at the CBC, it is more likely that you have a polymorph nuclear leukocytosis. Diagnosis, I said earlier, high index clinical suspicion based on what? The chronology of symptoms and number two clinical situations in which the condition has developed. So that is very important. All these patients, a clinical suspicion should be there. Only then go ahead and do investigation. The patient is having associated comorbid condition, like example, strenuous physical activity, dehydration, drug-induced, so on and so forth. You see the whole list. So all these are there. So the chances of having ischemic colitis are further increased. The differential diagnosis, not very difficult. You can have infectious colitis, you can have IBD or irritable, inflammatory bowel disease, pseudomembranous colitis, you can have diverticulitis, colonocarcinoma, and if you have very severe form, then it has to be differentiated from acute mesenteric vein thrombosis. The investigations are not very difficult, not very many. A plain skygram can help you with the thumb printing. This is what a thumb printing looks like. And what is the thumb printing there? Because of edema, the hostrations. So in all these patients, if you have thumb printing, it indicates that there is edema of the wall, usually caused by colitis. Number two, the nostril become thickened at regular intervals, appearing like thumbprints, which give the sample or the associated lumen. That's how it looks like. See the thumb, and this is how thumbs looks like. That is the thumb. There's the thumb, right? Now, a barium enema can be done. Infarction and perforation can be seen as a peritoneal air, pneumatosis, intestinalis, colon, and air in the portal vein. So you can have barium enema, you can have a CECT, you can get an ultrasound abdomen done, and it is usually good in the early stage of colon wall resulting from ischemia that can be diagnosed on ultrasound, but later in the day, ultrasound becomes useless. A color Doppler sonography can be used to differentiate between inflammatory and ischemic bowel thickening. Or you can do a indium 111 or a technetium 99M labeled leukocyte CT scan or a coronography, right? In all patients with colonic hypoperfusion, because remember what is happening in ischemic colitis, colonic hypoperfusion. So what should be done in all these patients is that these patients should be looked for and taken care. If possible, the hypoperfusion should be tackled. Whatever the reason, immediately correct the hypoperfusion, right? Patient presents with mild symptoms, OPD management is good enough, clinical improvement within 20 to 48 hours, and complete recovery within about this is not 2 weeks, I'm sorry, it should be 2 months and not less than 2 months, right? So partial recovery within 2 weeks and complete recovery only after 6 to 8 weeks. If it is a more severe form of ischemic colitis, then the patient has to be admitted. So this was OPD therapy. OPD, this becomes an IPD therapy, or the patient has to be admitted. Again, what do you have to do? Take care of the heart. Perfusion should be normal. The oxygen supply should be normal. So do whatever you have to. Bowel should be rested, with or without a Ryle-Steven position. IV supplementation can be given, and that can be substituted with parenteral if perhaps the nutrition, IV nutrition is to be continued for a long period of time, or unfortunately, large segment of bowel has been removed. In all these cases, we like to do that. Give this patient a TPN, right, or a parenteral nutrition. IV supplementation and patient antibiotic, and 20% of patients with acute colitis will require, ischemic colitis requires surgery with an associated mortality of 60%. See the mortality, 60%. So that means an indication of 20%, you're killing of 60% of those 20%, right? Severe reversible injury when segmental ulcerative colitis exists, the colon may take 1 to 6 months to heal. A regular follow-up to identify developing colonic strictures or persistent colitis is a must in all those patients who present with non-gangrenous ischemic colitis. So while on conservative therapy, what are you monitoring this patient for? Number one, local symptoms, local signs, and number three is basically the disease process that you're looking at, right? So persistence of aggravation of pain and vomiting and administration, peritoneal signs of generalized tenderness, guarding indicating perforation, systemic feature fever, lab parameter. So all these could be there in a patient who's on conservative therapy for ischemic colitis. Now, failure of this therapy in the form of failure of clinical improvement within 48 hours. So don't wait for more time. At this time, either repeat endoscopy or imaging may probably be useful to re-examine the severity of the disease. Number two, a surgical option should be immediately resorted to. So in a patient who has had some kind of a failure to the clinical therapy, surgical therapy is indicated in the form of worsening of peritonitis, number one. Number two, uncontrollable bleeding, and number three is you have to improve on the outside, right? The chronic forms of ischemia, so that was the acute form of ischemia, which could be a gangrenous, non-gangrenous, and partial. Now, opposed to that, a chronic ischemia, you don't find gangrene. What is happening in this patient? This patient presents in two forms. Number one, either stricture or as a segmental colitis. So segmental colitis or stricture. Segmental colitis presents as bleeding, diarrhea, pain, may respond to topical steroid preparations. Otherwise, remember ischemic colitis, no role of steroids. Resection of the affected segment is curative, and subsequent development of further ischemia disease is rare. So in segmental colitis, if you're using local steroids, these patients respond very well, and subsequently they may not require any treatment. But if the patient has a stricture, that stricture could be very a minimal stricture, the lumen is still adequate enough. Just observe this patient, don't do anything else. If it keeps on decreasing within 12 to 24 months, instead of recovering, it is static or decreasing during these 24 months, that is 2 years. In these patients, you like to do something for the stricture, either as an endoscopic balloon dilatation, or number two is segmental excision or resection of them. The endoscopic dilatation and segmental resection are two things which can be tried out. The last thing is functional constipation. How do you define constipation? That is very important. I would say why important? Because it's got a lot of therapeutic and prognostic implication. Otherwise, may not be so important. So how do you define it? Number one, a hard stool. I'm currently passing hard stool. I may like to call that patient a patient of constipation. Or number two, frequency of defecation based on a frequency of defecation. So number one is the consistency where you have hard stool. Number two, frequency. What about the frequency? Less than 1 in 3 days. That means you do it every third day or the fourth day. Number two, 3 or 4 or fewer times a week. So these are the definitions how you recognize constipation. Or you can take resort to the Rome 4 criteria for constipation, which states that the patient must have experienced at least 2 of the following symptoms over the last preceding 6 months. In these patients, basically the Rome criteria applies in these patients, and this Rome criteria helps to diagnose a patient of this disease, basically constipation. And what are we looking at in the Rome criteria? There are a lot of features to be looked into. Just to name a few, you are looking at spontaneous bowel movement. You are basically straining for more than 25% defecation attempts. Hard stool is being passed. So ultimately, what is happening on these patients is that there has to be increased training, ultimately translating itself into constipation. The causes could be anatomical, any kind of obstruction. Let's say there's kinking of the bowel, the narrowing of the lumen and stricture formation. Any can lead to a chronic constipation scenario. Pharmacological drugs are important, and this gives you an idea of pharmacological drugs which are commonly causing constipation in these patients, or there could be illnesses which are associated with constipation. So this has to be seen associated conditions, and these are a list of associated conditions in which you can have the development of this disease. The other things in etiology could be functional constipation, and functional constipation is further subdivided into obstructed defecation, slow colonic transit, rectal inertia, and anismus. Any one of them, right? So that is the etiology. For signs, symptoms, obviously, patient is constipated. We just now defined constipated. Apart from that, he feels bloated, low back pain, non-specific abdominal pain, loss of appetite, anxiety, all could be part and parcel of a patient having chronic constipation. If we do a digital rectal examination, abdominal examination in these patients, there is pain or defecation. These are the rectal presentation, the rectal bleeding from hemorrhoids is there. These patients tend to develop hemorrhoids very fast. Spurious diarrhea could be there, or there could be feeling of incomplete evacuation. So all these features are either abnormal presentation or rectal symptomatology presentation. I want to investigate a patient chronic constipation. What do? I rule out a structural abnormality. Point number one, that has to be done. I am treating a patient with chronic constipation functional, and all the time he had a stricture upstairs. So rule out a structural abnormality by doing a colonoscopy, doing a CT virtual colonoscopy. I can do very many. In any of these patients, you can do what is in any patient, these can be tried. What about functional causes? So once you have ruled out the structural abnormality, now you start thinking in terms of functional abnormality. And what are the functional abnormality looking at? Defecating, proctography, you can do anorectal or a rectal manometry, you can do a colonic transit time, you can do what's known as surface anal electromyography, or you can do a balloon expulsion testing where we use where the balloon injected into the rectum, and as soon as the patient gets urge to defecate, he immediately expels the balloon. So that can be taken help of in diagnosing these patients. Condition resembling chronic constipation is what is known as anismus, and this is also known as spastic pelvic floor syndrome. It has got a number of attachments to it. It could be anal sphincteric dyssynergia, a pelvic floor dyssynergia, a dysgenic defecation, and paradoxical puborectal contraction. All these conditions will lead to a chronic constipation. Now, in the form of functional obstructed defecation, this is basically what is happening in these patients. We've got functional is that the rectum, the colon is trying to contract. Now, when that contracts for defecation to occur, the sphincter has to relax. Now, here the sphincter is not relaxing. Which sphincter are we talking about? The pelvic floor muscle. So it doesn't relax. So what's going to happen? The downward pressure is being exerted and the door is closed. So patient becomes constipated, right? So why does this? Why? So either there could be decreased amount of propulsive force, or there could be a decreased amount of relaxation of the closure force. So defect in either one of them. Either propulsion is not effective, or there is a defect in the relaxation of the sphincter muscle. So that is the muscular hypothesis. So there is a malfunction. I told you the puborectalis is the levator ani part, and the external anal sphincter is the lower part. So there is a malfunction in either one of them. A normal defecation, I told you, involves the relaxation of both of them. But in this scenario of chronic constipation, what's happening when the muscle colon is when the muscle colon is contracting? With this contraction, what's going to happen? There should be relaxation by my pelvic floor. That's not happening. So the paradoxical contraction is there, and that leads to increase and regeneration of force from the colon. Ultimately, the colon stops exerting force, and the patient is frankly constipated. It can also present as tenesmus, constipation, and painful defecation, and gradually increasing fecal impaction. More common in female than in men, and sometimes shared with sexual abuse. That is the anismus way. Now, treatment of constipation, the mainstay is dietary fiber. Number 2 are drugs. Number 3, pelvic floor training. Number 4, invasive methods. And what are the invasive methods? Rectal irrigation can be done. Sacral nerve stimulation can be carried out. Or you can do what is MACE. And what is MACE? MACE is Malone's antegrade colonic enema. Malone's antegrade colonic enema. So these are the methods of tackling constipation. And what is the Malone's antegrade colonic edema? If you remember the lecture on appendix, if you happen to attend that, if you're not, we'll again talk about that. In a patient with chronic constipation, often what happens is that the appendix is brought to the surface as a ostomy. as an ostomy. The appendix tip is brought out as an ostomy. So that is now basically attached to the wall. And you can put in a catheter into the appendix. With the appendix, the catheter goes on the cecum, and I give the enema into the cecum. So this is basically what is happening. This is an antegrade enema. Normally, when you say enema, from where do you inject the enema? From the anal route. That is retrograde. Now here, where you are injecting the enema? Through the appendix into the cecum, and that is the Mellows antegrade colonic edema, or the mace maneuver carried out. Or else with constipation, you can also carry out surgery. To say the least, it is highly unsatisfactory and can only be contemplated or thought of in a patient who has got a generalized colonic transit. That means the whole of the colon, the peristaltic activity is defective. So what can I do? I can remove the whole of the colon. I'll do a ileorectal anastomosis. But as I said earlier, it's got a lot of morbidity. May not be so mortal, but a lot of morbidity, and that's why constipation treated with surgery is never beneficial. It's never beneficial. Medications are there. Medications are there. I just now told you high bulk diet. Apart from that, bulk forming agents could be used, or you can soften your stool. Soften your stool, or you can use a rapidly acting lubricant in the rectal area. You can use prokinetics, which tend to stimulate your peristaltic activity, right? Or you can use a stimulant laxative. Newer drugs are there, and some of them are being very favorably being used. Among them is what is known as prucalopride, is a prokinetic selective 5-hydroxytryptamine 4 receptor agonist that stimulates the colonic motility. And let me tell you, it's a very, very beneficial drug. It has a very good effect on a number of patients. So prucalopride is a prokinetic selective 5-HT4 receptor agonist. You can use an osmotic agent, again commonly used. Lubiprostone is a drug which is not uncommonly used. You can use lactitol, which forms a part of number of laxatives. Lactitol has been used at that time. Or third, you can have a third drug, that is unilate cyclase, which is a drug which is usually useful in those patients where chronic constipation is caused by irritable bowel syndrome. Irritable bowel syndrome, I'm not going to touch on that this time. It's a huge topic, more for the medicine people to tell you what IBS. But just remember, IBS of two types: one is colonic, constipative type and diarrheal type. So IBS-C and IBS-D. It is the C type, the IBS-C type, the constipative type, that usually responds to these guanylate cyclase agonists. Or you can use the peripherally acting mu-opioid receptor antagonist, usually in those patients who have had a constipation because of a use of morphine or related drugs. So opioid-induced constipation in adults can be tackled with these peripherally acting receptor agonists. So that finishes chronic constipation, and next time we'll be talking about carcinoma of the colon. If you have any questions, you can address them to me. Thank you for your time.